Good afternoon, everyone. Today, we are delighted to present this webinar on molecular diagnostics and surveillance in HPV-associated oropharynx cancer. My name is Miriam Lango, and I'm the Vice Chair of the Mucosal Section of the American Head and Neck Society. Lisa Schneider is the Chair. This year, we surveyed our membership to determine topics of interest to our members. The role of molecular diagnostics in HPV-related oropharynx cancer came up as an area of intense interest. Molecular diagnostics have come a long way in other tumor types, but are still relatively investigational in head and neck cancers. Dr. Patrick Ha, Chief of UCSF Division of Head and Neck Surgical Oncology, has put together an illustrious panel to update us on the state of the science. I do ask panelists and participants to avoid mentioning or endorsing any specific products or companies. And with that, I will turn it over to Dr. Ha.
Great, thank you so much, Dr. Lango. So welcome everyone. Again, my name is Patrick Ha, I'm the Chief of Head and Neck over at UCSF. And more importantly, I'd like to really spend a moment to introduce our wonderful panelists and thank them for their time. So yeah, our goal is to focus on molecular diagnostics, and it ranges from the maybe what we think is simple, but maybe not so simple, all the way to the more complex and how do we integrate this into the various treatment paradigms. So we're hoping to cover a lot of ground tonight. So in order to do that, we will start with Dr. Bishop, who's a professor of pathology at UT Southwestern. I had the pleasure of working with him over at Hopkins during our time together. He's extremely highly published, very well-renowned in the field of head and neck pathology, but also specifically in head and neck and HPV-related disease. He has numerous honors, numerous editorial boards, and I know he's going to give a great talk tonight about molecular diagnostics in terms of kind of the workup and the initial thoughts. And Dr. Fokker needs a little introduction, especially in the field of HPV. So she's a professor at Johns Hopkins, director of the Head and Neck Cancer Center, and executive vice director of the department. She's, again, is world-renowned for her work on epidemiology of HPV. So I'm curious to see what she thinks about the state of HPV molecular diagnostics. And then we have Nishant Agarwal, who's the chief of the section of otolaryngology at University of Chicago, who's done a lot of work in terms of detection. And so we'll listen to some of his thoughts and his work looking at detection of HPV in circulating cells. So we will have some time at the end for a couple of quick cases, but also if you do have any questions, please place them in the Q&A. We'll try our best to get to them. And I think JJ left something in the chat as well, but we hope to get to those questions as well as we go. So without further ado, I will stop sharing. And Dr. Bishop.
You're muted, Justin.
Okay, thanks for that intro, Patrick. I like the picture in particular. I have a lot more gray in my beard these days. But that's okay, I guess we all do. Let's back this up a little. Okay, so yes, I'm Justin, I'm a pathologist, so we'll just talk a little bit about HPV testing in tissue. Like Patrick says, it's sort of straightforward, but always good to have a little bit of view on kind of the way we're doing things in real diagnostic pathology these days. It was a little bit of a Wild West for a while there. Kind of everybody was doing something different, and in terms of HPV testing and head and neck cancers. And finally, about 5-6 years ago, there was a little bit of order put into all this when the College of American Pathologists convened this panel, and we did create these HPV testing guidelines, much needed, evidence-based, and it basically gave all of us a little guidance on what we should be doing and maybe what we know and maybe what we don't quite know yet. So that was a good experience, and it also helped us all kind of be on the same page in terms of what is recommended doing in tissue. These are them. There's 14 of them, not all of which are kind of daily use. I was just going to go over the particularly pertinent ones very briefly. This was published in 2018 in Archives of Pathology. So as we all know, the oropharynx is the main hotspot for HPV-related carcinomas in the head and neck. That, it's tonsillar crypt is the place that these the virus is infecting and carcinogenesis occurs for a variety of reasons that we don't have time to get into. But this is what it looks like under the microscope. The tonsillar crypt is the magic zone, and in recognition of the particularly unique cancers and anatomy, for the first time relatively recently, we finally kind of gave the oropharynx its own section and its own cancer types in the WHO classification of head and neck tumors, which is kind of our Bible of diagnostic pathology. Up until 2017, it was all kind of lumped together and kind of regarded as part of the oral cavity, which is kind of shocking when you think about it. Just very briefly, we know a lot of this, I know, just for review, how very different HPV-related and HPV-unrelated head and neck cancers look under the microscope to us pathologists. For the most part, HPV-negative cancers arise from dysplasia and invade as cords and nests. Very, very pink, glassy cells, forming obvious keratinization and inducing this desmoplastic stromal reaction. And HPV-related oropharyngeal carcinomas, of course, look very different. They don't arise from dysplasia. Instead, they arise from the tonsillar crypts, as I mentioned, and they closely mimic what a normal tonsillar crypt looks like, to the point where it can be very difficult on frozen section, for example, to tell, is this just a regular crypt or is it a small cancer? So yes, you can see it's very blue. It doesn't show that pink keratinization, doesn't induce desmoplastic stromal reaction, and there are a lot of inflammatory cells both in and around the tumor. So in straightforward cases, they're obviously very easy to distinguish, but of course they don't always follow the rules. But that's a hard and fast rule. And when they metastasize, of course, HPV-related oropharyngeal cancers get very, very cystic. And for that reason, they typically present as cystically necrotic metastases in patients who often don't even know that they have a tonsil cancer. And because of that, very, very often the first diagnostic material that we get is fine needle aspiration. You stick a needle in it and you may be thinking it could be a branchial cleft cyst or something else benign. I'm not a cytopathologist, but my understanding is this is a typical appearance of fine needle aspiration of an HPV-related oropharyngeal carcinoma metastasis. There are some unique features that are particularly unusual about these carcinomas. We don't have time to get into all of them, but one of them is the concept of invasion. HPV-related oropharyngeal carcinomas can metastasize even when there is no overt invasion, as this case did. And it all goes back to the microanatomy. It has to do with the fact that the basement membrane in the tonsillar crypt is very porous and basically does not serve as an effective barrier. So it's kind of a weird concept that even today, some of my pathologist colleagues are not used to, particularly if this is not their usual area, is the fact that there is no carcinoma in situ or dysplasia when it comes to HPV-related oropharyngeal carcinoma. As pathologists, is just a very unusual foreign idea to us. All right, so getting into HPV testing, I think we all know why to do it. We don't have to get into that. So let's go over some of those guidelines. The number one, of course, most important guideline was that, yes, high-risk HPV testing should be done on all newly diagnosed oropharyngeal squamous cell carcinomas. That may seem obvious to us now, but again, at the time, this was not being routinely done necessarily everywhere. So yeah, you can do the testing not only in the primary, but it can be in the metastasis as well. And we shouldn't do it on non-squamous carcinomas. Again, may seem obvious to you, but definitely we've seen HPV testing performed on all sorts of tumor types, not necessary to do. How to do it, of course, only high risk is all we're interested in, particularly type 16, which of course is the big player in these cancers of the oropharynx. Again, this may seem obvious to some of the listeners, but low-risk HPV testing is absolutely not needed or important in any way for head and neck cancers. Yes, these cause papillomas, they cause warts, they certainly can be very morbid, but they are not causes of oropharyngeal squamous cell carcinoma. So yes, I still to this day get a lot of cases sent in where they did both high risk and low risk HPV testing. Just save your money. That is one of the guidelines. Don't worry about low risk HPV testing on these cancers. In terms of methodologies, there's certainly no shortage of ways to test for high risk HPV in tissue, which is of course my main concern as a pathologist. I've listed all of them here. We're not going to talk about all these. Of course, the main testing method that is still most prevalent is a surrogate for high-risk HPV, and it's of course P16. We all understand the molecular mechanisms for testing for this as a surrogate has to do with the downstream of retinoblastoma protein leading to an upregulation of P16, which of course very easy and straightforward for us to detect under the microscope. There's a lot of advantages to doing HPV testing in this way on tissue. For the most part, everybody's got it. It's easy to do. It's relatively inexpensive. It's incredibly sensitive for high-risk HPV, approaching 100%. Not quite, but approaching. Pretty darn specific in the oropharynx, which is obviously what we're most concerned in. Testing, you do kind of need to follow criteria. This is less of an issue now that it's kind of more widely used, but there were certainly times where we'd get a case sent in that was called positive, but it was just kind of this patchy staining. So we do want to follow these 70% diffuse nuclear cytoplasmic. And we all need to realize that, of course, P16 is quite terrible as soon as you leave the oropharynx or cystic lymph node setting. You're talking about larynx, you're talking about lung, it's basically has no value for high-risk HPV testing. The other particular technique that I was going to discuss is RNA in situ hybridization. This is kind of the best, in my opinion, method to use in tissues. It's close to equally sensitive as P16, but much more specific because you're actually detecting the E6, E7 transcripts, which defines what transcriptionally active HPV-driven tumor is. I say it's not yet widely available on automated platforms. That is rapidly changing to the point where this is really feasible for a lot of labs to do, not just the big reference labs, which was the case a couple of years ago. So yeah, a couple of the more guidelines dealing with this. P16 at that time, there was by far the most evidence for using this as a surrogate. So that was the recommended testing modality. Of course, we did add the caveat that additional HPV testing in addition to P16 could be done at the discretion of either us or the clinician or whoever. We said, you know, not only in the oropharynx, but also in the metastatic setting. And we did put the criteria, the 70% that we discussed is one of the guidelines. Something that is definitely worth mentioning, as I said, very often the first material we ever see is fine needle aspiration, right? It's not actual tissue, but rather FNA. And in here, HPV testing guidelines get a lot less straightforward. P16 you can use on a cell block. Of course, you can use any of these techniques, but for whatever reason, P16 is just not as good in cell block material as it is in actual tissue. So here is a situation not rare at all. We have patchy staining, a little bit of contiguous staining, but it's far less than 70%, and yet the in situ is very, very strongly positive. And in the tissue itself, it's typically very strong. So, and also P16 can be positive in other things. So just be careful with P16 in the FNA setting. And so as far as the CAP guideline go, at that time, we just didn't have a lot of evidence for any particular testing modality. We did say if it's negative in the FNA and you get tissue later to repeat that testing. As I said, that happens a lot. The FNA is either equivocal or negative, and you get tissue later and it's very strongly positive. And then in terms of HPV testing outside the oropharynx, very quickly, you know, there are other sites where you can see HPV-related cancers. For the most part, they're quite rare. And also, for the most part, we don't know what it means even when you find them. And so for that reason, at that time, we did not, recommend routine HPV testing on non-oropharyngeal head and neck cancers. So here's once again as the guidelines, easy to find. And then I will just say that we are, Carol and I and several others are a part of this updated guidelines, looking at the newer evidence. So maybe we can come up with some even more up-to-date testing recommendations. Thank you.
Great. Thank you so much, Justin. So next I'd like to introduce Dr. Fakhri, who's going to be talking a little bit more about other molecular testing that can be done. Thanks, Carol.
All right, thanks for the introduction. It's fun to do this with Patrick, Nishant, and Justin, as we were all kids together doing some of this work. And I wish we were all not doing this through computers, but it's great to get together. All right, so I'm going to be talking about some of the background data on circulating tumor DNA. We know that HPV is clinically relevant in terms of risk factors, clinical demographic profile at the time of diagnosis, as Justin just reviewed, and in terms of prognosis. And given the prognostic advantage, and we have this great biomarker, I think we've all kind of always wondered, can we use this to think about alternative methods of surveillance and prognostication. So this is from Nishant's paper back in 2015, which really gets to what are we measuring when we talk about circulating tumor DNA? And we're looking at DNA fragments both in the plasma or in saliva. So I'm going to first review the data that we have on oral HPV. And so this was a study that I did with Maura Gillison. It was using patients or data from patients at Johns Hopkins and at Ohio State. And there were patients who were heterogeneously treated. Some had had surgery followed by radiation therapy, and some had just gotten chemorads. We had collected oral rinses on them during their radiation treatment. And what you see is that oral HPV prevalence decreases over time during radiation therapy, so that by the end, they don't have any. And for the patients who ended up who had surgery, you see that there was a decrease in prevalence of oral HPV from before surgery to after surgery. And then those who went on to get adjuvant radiation therapy or chemoradiation therapy, you see that there's a dose response basically decrease, suggesting that this is microscopic disease that goes away over time. And if you look at viral load, this is essentially a heat map of HPV-16, red being the highest viral load and white being negative. And each line represents a different patient with a tumor-related infection. And you see that over time, over the visits, you get an attenuation of the viral load. So you see that over time, the viral load of the HPV is reduced. Now, the other thing that you see is if you look at non-tumor type infections, so when you do an oral rinse, there might be a DNA type that is not related to the tumor. So the tumor is HPV-16, but there's an HPV-31 infection that's there. And what you see is that those generally just stay rock solid red. And so it's only the tumor type infection that goes down in viral load over time. Meanwhile, if you look at the non-tumor related DNA, it stays essentially solid and you don't see a change in viral load over time. So what does that mean prognostically? If you identify tumor type HPV infection in an oral rinse after treatment, it's associated with significantly worse overall survival, significantly worse recurrence-free survival, and worse local regional recurrence-free survival. In our study, distant metastases were not significantly associated with worse survival, although you can see that there's a difference on the Kaplan-Meier curve. And in terms of timing between the detection of oral HPV DNA and recurrence, This is a different study just to show that you see kind of a similar pattern, and it was heterogeneous in terms of the timing between HPV infection and the time of recurrence. 10 months in one patient, 6.9 months, 3.7, 7 months in another. And so it's kind of consistent with what you see in other studies that use oral HPV infection. And when you think about the performance characteristics of oral HPV DNA and how often people go on to develop recurrence, you see that here, of the 21 who had a positive or had an infection that was detected after treatment, 9 went on to develop a recurrence. And so this is consistent with data from Jamie Ahn and Joe Califano from a retrospective study at Johns Hopkins over 10 years ago now, I guess. The data was collected. And what you see is that the sensitivity and the sensitivity was low, yet the specificity and positive predictive value was high, and relatively low negative predictive value. So when you look at plasma, you see a very similar relationship. So this is work from Bisham-Shera's group at UNC. And what you see is when it's measured in plasma, HPV is detected initially, and you see that there's a decline in HPV DNA over time after chemoradiation therapy. And what you see is that detection of plasma HPV after treatment is also strongly associated with worse relapse-free survival. I'm sorry. And there are kind of different kinetics when you look at the plasma HPV. You see that some people clear very quickly and go, have a decline, whereas other people will initially have an increase in their HPV DNA. But it is consistent that the detection of HPV DNA after treatment is strongly associated with worse relapse-free survival, local regional survival, and distant metastases with the UNC data. And then when you look at performance characteristics in this cohort, what you see is that there's very high negative predictive value with plasma. Positive predictive value is about 54%. And this is using the definition of one test being positive. So detection of HPV in one plasma assay. However, if you use a stricter definition of 2 tests being positive, then the performance characteristics change. And so you have 100% negative predictive value, 100% sensitivity, 99% specificity, and relatively high positive predictive value. And in this study, 15 of 16 patients went on to develop recurrence. And then in terms of lead time, I would say that these were not necessarily prospectively collected at standardized times. And so it's hard to determine what the real lead time is. But in this study, it was about 3.9 was the median, with a range of 0.37 to 12.9. And you can see here among the patients who recurred, the time between the first positive test and the second positive test. And this is again to make the point that some people have a spike after treatment, and then they go on to decline. Other people go down and have a decline in their plasma HPV DNA. But over time, during chemoradiation therapy, you see that there is an increasing proportion of patients who have elimination of their plasma HPV DNA. And just to make the point here that, of course, we know that that there's both a episomal and integrated version of oropharynx cancer, yet we always talk about them in the same manner. And a greater proportion are episomal and have a higher viral load, essentially, that's detectable in plasma HPV DNA, and that may have some prognostic implications. with low baseline levels being more likely to be integrated and having worse prognosis. And this is data from the Boston group. And what they show here is that different levels of circulating tumor DNA in plasma may be associated with different sites of disease, namely being local regional versus pulmonary versus extrapulmonary, based on the magnitude of the detection. And is similar to the other studies, although in this case, there are recurrent metastatic patients who are included. You see that there are prognostic differences, and that these differences also can be stratified by site of disease. And you see in this waterfall the time between rising titer and disease progression. And so this is, I just wanted to add, kind of similar to the oral HPV DNA data at the beginning, where you see kind of pre versus post with surgery. We now have data for surgically treated patients. And there are two studies, one from the Mayo group and one from the Mass Eye and Ear group that I'll show in a sec. From the Mayo group, you see that if you compare pre versus post surgical treatment, you see that there is a rapid decline in prevalence of plasma HPV, and that again, if it's detectable after treatment, that is associated with worse survival. The Mass Eye and Ear group provides some data about the kinetics of plasma DNA just after treatment, after surgical treatment. And so what you see is that there is a rapid decline after surgery. So after 6 hours, essentially, you start to see this stratification between those who are going to have persistent plasma HPV DNA and those who have a decline in their HPV DNA. And this appears to be associated with specific tumor markers, or I should say tumor properties. So with increasing lymph nodes, the circulating tumor DNA is increased, and that burden declines with the stage of lymph nodes. Similarly, with extranodal extension, there's an association with gross extranodal extension and the degrees of extranodal extension and plasma HPV DNA. And you see the same thing by margins. So basically, it makes the point that with high-risk features that we see in our operative patients, they are more likely post-operatively to have HPV plasma that's detectable. And so this is, I think, one of the first studies to really show us how dynamic this actually could be. So all very exciting, and I think it tells us a lot. And we also all know that there are studies, the companies out there with a validated test that is clinically available to all of us. So I think it's worth also considering, you know, what is unknown and where do we struggle with this. I think these are some of the studies with data that show that there's a role to prognosticate. However, I think that, you know, we have limited prospective data where we have rigorous collection of samples within known time periods, so that we can be informed clinically on what to do. And, you know, we have NCCN guidelines in terms of surveillance, but they don't yet include plasma or circulating DNA for that matter. They do for EBV and nasopharynx cancer, but we're just not there for HPV. So what is really still kind of unknown? We really don't know what the lead time is between a positive test. We're not sure, I guess, what we call a positive test. Is it one test or is it two tests? And then what's the time between recurrence and a positive test? We don't know what the risk-benefit ratio is of essentially administering this and including in our clinical practice. We don't know what the recommended frequency is. You know, we know within NCCN guidelines how often to bring someone in surveillance in the first year, second year, and, you know, spreading it out. but we don't know what to do with what is clinically available to us now, despite very exciting research data. I think the performance characteristics are still not that well elucidated since we have limited sample size and we don't have large prospective studies yet to do that. And I think, I think the real question is, does this really change the clinical course, and does it change outcomes? Or are we introducing stress to our patients? And are we worsening their quality of life, or are we improving their quality of life? And I think we could probably all agree that with a negative test and high negative predictive value, that might be a good thing. But on the flip side, we might be introducing unintended anxiety into our patients. And does it increase interventions? If we have a positive test, what do we do with that, right? We have no guidelines around that scenario. And then I think the other part with any test, we always should be able to agree on how we counsel patients. And I think in the absence of large studies, we probably don't have that consensus yet. Is it cost effective? We don't know. On the other hand, if we have a negative test, does it reduce the frequency of clinical surveillance? And can we put those patients on a different pathway because they may have much lower risk? So in conclusion, we know that it's an independent marker of prognosis, and how that fits in with our current knowledge base of plasma HPV DNA, we don't know.
Great, thank you so much, Carol, for making all that so clear. So next we're going to have Nishant, who's going to talk to us a little bit about what we can actually do with this and how we could utilize this information more effectively. So thank you, Nishant.
Thanks, Patrick. Really, I feel very blessed to be here with Carol and Patrick and you all. Carol and Patrick are my Hopkins brother and sister, so it's nice to be together on Zoom. So I'm going to switch topics a little bit and don't have as much mature data as Carol and Justin presented, and we'll present a lot of concepts that institutions across the country are now exploring using HPV DNA to guide de-intensification for HPV-associated oropharyngeal squamous cell carcinoma. So as you can see, this is innovations in head and neck cancer, and I've shown this slide before, but there's been a flurry of activity, and the major advances in our understanding of head and neck squamous cell carcinoma have really been made only in the past 30 years. And as you can see also, there's a pretty significant lag in head and neck cancer discoveries versus other cancer discoveries. So for example, HPV was proven unequivocally to cause cervical cancers around 1983, as you can see here, whereas in head and neck cancer, that discovery was not made until the year 2000. And we always cried because we never had a PSA or a CEA equivalent. But now I think the times are changing, and we've made a lot of progress and really had the opportunity to leap forward ahead of other cancers in terms of our research and also our outcomes. So this is all really possible because of seminal work that Carol did. So in 2008, Carol published a seminal article on improved survival in patients with head and neck squamous cell carcinoma associated with HPV. And then in 2010, Ang et al. Confirmed the improved survival of patients with HPV-associated head and neck cancer, and firmly both together established that HPV status is a strong and independent prognostic factor for survival with oropharyngeal squamous cell carcinoma. So what's happened now over the last decade, there have been intense debates, including AHNS meetings, about de-escalation and how best to do it, whether it's a backbone of radiation, whether it's chemotherapy or surgery. And my message today will be, it doesn't really matter, but start thinking about using HPV DNA in these de-escalation clinical trials. So this is a study, sorry, let me skip the slide. So yeah, again, so regardless of how you de-escalate, we now have a biomarker to responsibly de-escalate. And here, what Carol described a lot was the work during treatment and after treatment to look at response to treatment and surveillance after the completion of treatment. And what I'm going to talk to you about is up here, which is equally important, is monitoring during treatment and adapting treatment, whether it's de-intensification or in some cases intensification. And I think there are two key factors with this. One is a baseline preoperative detection. So can an assay detect pre-treatment HPV DNA? And then the level of detection. And each assay has different performance, and I think this will be important going forward. So here's a study that Glenn Hanna from Dana-Farber is leading from the Harvard team called REACT. And here, Glenn and his team are incorporating clinical criteria, quantitative levels of HPV, and then clearance in assigning treatment arm. So you can see a low-risk arm is sort of low-risk T disease without significant smoking history and HPV ctDNA. And then this arm gets de-escalated into 2 cohorts. The intermediate arm is higher risk clinical disease with significant tobacco use history. And then you can look at the circulating tumor DNA, and they use, again, 2 criteria, either quantitative HPV DNA levels or clearance by 4 weeks. And Carol briefly mentioned this paradox where we see whether it's related to integrated and episomal DNA, but in their high-risk arm, they also use clinical criteria, either fixed nodes or T4 disease, but also the quantitative HPV DNA. And here you can see the quantitative HPV DNA fragments of less than 200 versus greater than 200 intermediate arm and less than 200 in the high-risk arm. So again, there's some paradoxical data suggesting that lower levels of DNA may be associated with a poorer prognosis, but I think this is still early data. So this is a study that is underway at Mount Sinai, and this is courtesy of Raymond Chai. So this is a surgical study at Mount Sinai where HPV DNA is integrated into assigning treatment arm. So there is baseline pre-treatment HPV DNA, and then post-op HPV DNA at 2 weeks, and prior to start of adjuvant treatment as dictated by pathology. So as you can see, if patients have undetectable HPV DNA, they're assigned to 2 groups, either observation or low-dose radiation with cisplatin. And then high-risk groups actually are taken off the study and treated based on pathology by standard of care. So this is also a very interesting study using HPV DNA after surgery in assigning adjuvant treatment, including observation. Another study from Mount Sinai, but this is more chemoradiation based. So in this study, patients undergo pre-treatment HPV DNA, and then patients receive induction chemotherapy and have HPV DNA testing at different time points during different cycles of induction. And then they're assigned to reduced treatment arm or standard treatment arm. And then they have a follow-up HPV DNA at 4 weeks of chemoradiation. So again, this assignment is based on HPV DNA levels. I couldn't get more specifics from Dr. Posner, but hopefully they'll have a schema and some of this early data published soon, because this is also a very exciting study. And then subsequent to the treatment, the patients have serial HPV DNA at different time points for up to a year. This is a HPV DNA assay that we developed with the CLIA lab along with our colleagues at Hopkins. And this is using next generation sequencing. And here you can see this is a dilution of contrived samples tested in replicates at 12 tier ranging from 0.3 copies to 50,000 copies of HPV. And really, I think the key part of this is the sensitivity and specificity and quantification of HPV 16 and 18 in the plasma of oropharyngeal cancer patients. So in terms of the analytical performance, you can see that over the range of 5 orders of magnitude, in a dilution series, you can, with a very high sensitivity, detect HPV DNA. And the low quantitative variability is observed with a less than 30% coefficient of variation above 5 copies. So our cutoff is about 5 copies of HPV DNA. So it's very robust. And in terms of the limit of detection is as few as 0.025% allele frequency in a background of about 20,000 wild-type molecules. So for us in the field, the cutoff was always 0.1%. So if we can detect anything in the 0.1% range or better, that would be potentially successful clinically. And here with this assay, we're able to sort of get below that 0.1% threshold. So this is some of the work that we are doing at UChicago. We're evaluating HPV DNA and local regional disease in patients treated with induction chemotherapy, followed by either de-escalation or standard chemoradiation for high-risk patients. And we collect HPV DNA, again, at different time points during induction chemotherapy and at the end, and assess response. And based on response and clinical risk stratification, we assign patients to different arms, and the vast majority of patients are able to be de-escalated. And here's some preliminary data from our work. Here you can see serial quantitative cell-free HPV DNA among the first 25 patients on our study. And you can see how we've seen sort of other data that Carol presented, the wide range of HPV DNA fragments. You can see lowest is about 5 to about 10,000 fragments pre-treatment. And in this patient, in this study, 1 out of 25 patients, or 4%, have recurred so far. And this patient in red had undetectable cell-free HPV DNA post-induction and during chemoradiation, but then became detectable about 6 months post-chemoradiation. And at that time, the patient was also salvageable, so he underwent salvage surgery. And a closer look at these results. So again, an initial of 25 patients who were eligible and started protocol, and all of them had baseline positive cell-free HPV DNA, with again a wide range of about 5 copies to almost 10,000 copies. And again, of the 18 patients, 17 out of 18 had undetectable DNA at the end of induction chemotherapy. So this patient had positive DNA at the end of induction and underwent TORS and neck dissection, and now has had undetectable HPV. And again, this other patient was a single patient who recurred and was detected at 6 months and then underwent salvage therapy. So you can see in all of these studies that risk and response adaptive de-escalated chemoradiation or surgery followed by adjuvant treatment is a very promising strategy to really dynamically select patients for de-intensified treatment. Now, this is slightly a different concept. So I talked about treatment adaptation, and this is now about maintenance therapy. And I borrowed this slide from Bridget Ma from Hong Kong, who is using EBV for nasopharyngeal cancer to guide maintenance therapy. So in the high-risk group are patients with detectable EBV DNA or partial disease or partial response or stable disease, versus the low-risk group has undetectable EBV DNA. So I think this is another very unique concept. So other than treatment de-escalation, can you also use tumor DNA for maintenance therapy. And I talked a lot about HPV DNA, but there are definitely other biomarkers. So this is Dr. Nancy Lee and her group at Memorial Sloan Kettering, who use hypoxia as a marker for treatment de-escalation. And the MSK team reported their data with a 1-year local regional control of 94%. So also really, really great outcomes. So really the ultimate goal is to be here while we're still here. We give everyone the same therapy. Most patients we are able to help. Some patients have stable disease and other patients either have progressive disease or have side effects, including short and long-term related to our treatment. And our goal is really using biomarkers, whether it's HPV, hypoxia, or other biomarkers that will come down the line, is to really tailor the therapy for individual patients so everyone benefits. So in conclusion, I think screening, we're not there yet for HPV. We think for HPV negative disease, screening will be impactful. Carol talked a lot about surveillance, and then we talked together a lot about monitoring and surveillance. And again, monitoring is critically important for response adaptive treatment, where you can either de-intensify or intensify treatment. Also maintenance therapy as the novel concept from Bridget Ma, and then of course for prognosis. So thank you again for all your time. It's really a pleasure to talk to you all. Thanks.
Great. Thank you so much, Nishant. Thank you to all the speakers. Those are great talks, and for everyone for staying on time. While I pull up a couple cases, there's a question in the Q&A from Dr. Yarbrough about, I'm going to direct this one to Justin, about in the non-HPV setting, can you have precancer, or is it, or CIS, so to speak, if it's remaining above the basement membrane?
Yeah, very good question. So it all has to do with the of that surface epithelium, the surface squamous epithelium. I have no issues calling it that at all, even if it's in the called oropharynx. However, if it's something that looks like conventional dysplasia and it's creeping down into the tonsillar crypt epithelium, that's where I would have difficulty calling it that. Fortunately, that's not common, that scenario. It's usually pretty straightforward. This is.
Oh, you may be chopping up a little bit there, Justin.
Good question.
Okay.
Did you get any of that?
It got a little choppy at the end there.
Yeah, it's choppy here too.
Okay, maybe you can leave your video off and you can stay on audio.
Okay. We'll do.
Okay. Great. I have a couple of just very quick, hopefully very practical cases to talk about things that we see almost every day in clinic. And so the brief thing is we have a patient with a cystic neck mass, and we're obviously worried, he's a 46-year-old guy, and we're concerned this is cancer. So first question to any of the panelists is, who does the FNAs at your institution? Do you do this yourself? Do you send to radiology? Is there a pathology team, or how do you manage that? Nishant, you want to start us off?
Sure. So for us, we generally send it to radiology with ultrasound guided FNAs, and we ask them to make a cell block, as Justin talked about earlier, so they can test for P16.
Carol, anything different?
The only thing I would add is I would want more, if it's an unknown primary, I would want HPV as well. I'd want something specific.
Okay, and so again, under ultrasound guidance, I assume for these cystic nodes, I think that makes sense. And like Nishant said, he would request cell block and HPV testing. Do you guys ask for P16?
Yeah, I think that's what Nishant's saying. P16. I would also add to that we should.
Okay, got it. Okay.
Have ish.
Justin, on the receiving end of these instructions or these tests, You mentioned that P16 was pretty variable in these samples. Do you find them helpful at all?
Can you all hear me now?
Yes, we can.
Okay. Yeah, we do it. We do P16. It's just so standardized and so like prevalent. Everybody does it. It's just the interpretation you just got to be careful with. So when it's positive and diffuse, it's easy, and that's great, and it's helpful for everyone. The trick is when it's kind of equivocal or low-level positive. So you can either just call it equivocal and leave it at that, or follow that up with something more specific, like in situ hybridization, which is what I would recommend.
Okay, Sumi said that's what he'd recommend. Okay, great. Simple, straightforward case. All right, so now we have a case of a guy, patient who had an N3, node, one of these large, 6 or 7 centimeter nodes that we all contend with, had chemo and radiation because none of us were that excited about operating on this patient. And then on the 3-month post-exam, and you can feel this thing, it's still there, it's smaller, patient feels fine. And so, what do you do then with this patient? So you're now 3 months out from chemo and radiation. And I believe you have a polling question, JJ, if you're able to pull that up. Just wanted to poll the audience to get a little interaction here. Okay, so you can see hopefully the questions on your screen. And so we'll give it a few seconds here. So would you recommend a neck dissection? Would you just observe, get some imaging in a couple months? Would you stick a needle in it of some kind? Or would you get some circulating HPV blood testing?
Okay, we'll
Yes, we are not allowed to vote.
Yeah, we'll close the poll in about 10 seconds. We get about almost 50% voting.
Great, maybe I'll have the panelists start answering the question. So, I don't know, Carol, what would you do in this scenario?
Talk about it at tumor board with the rest of the team. But I think there is probably enough literature to suggest that 3 months, especially if you have a PET and it's kind of marginal, that might be a little bit early in HPV positive, and so you could do it a little bit later. So it just depends on how, we can't see the PET scan. It depends on what, the degree of avidity is. Without a PET scan and with, seeing a scan like that, I think that I would, we would have the conversation of having, doing an FNA, but, even in the absence of a positive diagnosis, I still think that we would advocate for surgery in that case, because you can still have a false negative in that situation. And you bring up the question of circulating HPV tumor DNA test. It would be nice, but I think that given where we are as a field, if it were positive, I think it would, make us feel better about the decision that we're making. But if it's negative, I'm not sure that I would 100% rely on that at this point, just because I don't think that we have consensus as a community with that.
And Dr. Rocco in the chat brought up some good points that, I didn't show the PET kind of on purpose, but, are they smoker or not? And this might influence your decision as well. Actually, JJ, are we allowed to see the results?
Yeah, if you're ready, I'll show them now.
Go ahead. Oh, pretty mixed, huh?
Yeah.
Justin, maybe you can speak a little bit about these post-treatment FNA/core. Do you have any advice for those of us who might order these, or how useful do you think they are, like this early treatment phase?
Often disappointing. So yeah, it's like if you get obvious cancer, great, but they're often very necrotic and kind of disappointing in my experience. Is that y'all's experience?
Yes, I agree. It's hard to use it to guide therapy because sometimes the pathologists aren't convinced that these are viable or not. And, you're kind of back to where you started sometimes. Okay. Let me quickly go to the last thing here.
Patrick, may I make one point?
Yeah, go ahead. Nishant,
You know, I think all these answers are correct, and I think the fourth choice is sort of evolving, but our treatment for this has also evolved. If you can imagine, a few years ago, for every N3 disease, we always had planned neck dissections, and now we don't routinely do it. So I think, as you can see for other responses, I think these are all correct, and I bet you HPV DNA will soon really give us an answer for this. But we don't have mature data to use that right now.
Yeah, good point. Okay, 64-year-old patient, neck mass, throat pain. Boy, too many windows. And this is a classic P16 positive cancer, and we ended up doing the circulating tumor tissue testing. We had 313 to start. Because of the low burden of disease, the patient opted for a transoral resection. And so we have this pathology showing, a single node, the primary was excised, and there was a bit of extranodal extension, although it may be perhaps debatable. And if we can go to the polling question 2, please. Okay, so the question is, at this point, I'm not giving you all the information yet, but a little bit of E&E, negative margin, single node, HPV positive, non-smoking gentleman. What would you do for your next steps after the resection?
We'll close the poll in 10 seconds.
Okay, maybe Nishant, you can start answering as we close the poll.
Sure. Yeah. So I think you alluded to some of the points. You said a little bit of E&E, so I think the extent of E&E will be important. E&E doesn't seem to be the same for HPV positive versus HPV negative disease, but based on sort of the highest level data with extracapsular spread, you can consider chemoradiation. That would be sort of the data that we have there. But I think, again, a lot of these things are evolving. You can't use HPV DNA right now because we don't have the mature data, but I think that will come.
Okay, can we go into the poll? Interesting. So people are kind of hedging their bets on what that E&E means, I think, right? They're thinking radiation maybe alone is sufficient. Okay, can we quickly go to the last polling question here?
It's a dirty secret too from pathology that E&E is not always so straightforward either from our perspective. Don't tell anybody.
Yeah, I didn't want to break that out here, but this patient
actually did a good
actually
job of publishing that, though, Justin.
Yeah, this patient actually, there's some debate about the E&E status, but nonetheless. Okay, so now we get the patient actually kind of delayed and was kind of making up his mind. He said, hey, it's been 6 weeks, let's just get another test, see what it shows. And now the HPV test is undetectable. Does this change any of your thinking? I don't know, Carol, you want to take a stab at this while people are answering?
Yeah, I mean, I guess what I would say is from the beginning, before you showed this question, I think it's nuanced, and I think it's a discussion as a multidisciplinary group, and it's a nuanced discussion with the patient. And as Nishant said, we're just not there. We all kind of have a hunch of where the field is going. That being said, we still operate within kind of consensus guidelines, and I think we probably all feel most comfortable giving patients the recommendations based on what we know. And while there is their extranodal extension is imperfectly measured between pathologists, and while there are grades of it, in underpowered studies, there's a question of its prognostic significance, but in adequately powered studies, extranodal extension remains a prognostic factor in HPV positive disease. Now, it may not be as strong of a prognostic factor as it was originally described in HPV negative cancer. So I think all that to say that it is nuanced, and I think, giving a patient has to understand all of that, right? They have to understand that, why was chemo recommended, and in the context of, adjuvant chemoradiation therapy with extranodal extension, what does it mean for a patient like this, and that he she had a low burden of disease, and what may we derive from a plasma assay which is negative at this point, and it doesn't show anything detectable, but that this is a subject of clinical trials, and we would be operating outside of the context of clinical trials. So that's my long-winded answer to that question. And some patients decide that that's they just want to take the risk and they want to undergo surveillance, just like they did that without any having a biomarker, right? Like we've all had those patients who made that decision in the past. And I think I still see one of your patients, Patrick, from years ago, who I remember first seeing him thinking like, man, the guy had several nodes, and yet he never recurred. And I think there's a lot that we don't actually know in terms of when we risk stratify, because I think we've also all been surprised by people who are non-smokers, have a low burden of disease, and yet do go on to do poorly. The last thing I just want to say is, in this scenario, what would make me even more comfortable if we were going to follow circulating tumor DNA is that you say that it's P16 positive, but I don't know that the tumor is HPV-16 positive, right? It probably is, but if you're going to follow the biomarker, you want to make sure that it's concordant with a tumor type infection, which we don't know from this scenario.
Point.
Patrick, can I make one more point? So the half-life of HPV or any tumor DNA in circulation is pretty short. So I can also leverage doing multiple tests to really give you a signal early on when you still have that window for adjuvant or salvage.
Yeah, I guess the question is, when will it start to rise, right? Like it requires probably a certain burden of disease before it actually becomes evident. It may not happen during the first 6 to 8 weeks, let's say. Okay, so just based on those, looks like nobody really changed their mind, at least from my recollection of the answers. But the percentages were pretty close to the same on the poll. Okay, we are running out of time, but there's one question, Nishan, you saw in the Q&A. Do you want to briefly take a minute and?
Yeah, these are about the different HPV assays.
Yes, yeah.
Yeah, I think there are a lot of assays that are available or are under development, and I think we just have to be very critical of the test performance and really be very rigorous in our analytics before we use it clinically. So I don't know specifically about this lab, this CLIA-based lab, the anonymous attendee referred.
No, it was the one before that, actually. Whether which lab do you use, and do you have or is it a research study, or is it more of a?
We use a commercially available CLIA certified lab, which is not in-house. It's an external lab.
Yeah, and I think maybe the first part of that question has to do something with, like, could you get like an HPV infection, or let's say you had cervical cancer or precancer, would that cloudy the data on your circulating levels?
What was the question, Patrick? Would
if you had a non-head and neck site HPV infection,
you would get that in circulation.
Yes, and that's the thing, you can have an anogenital, right?
Yeah.
So I think any advanced stage HPV-associated cancer will give you circulating HPV. Yeah,
great. Okay, on that note, we are running over time, but thank you so much to the panelists and especially to the organizers, to Dr. Lango and Dr. Schneider, for introducing this and proposing this as a panel. It was great to be able to put this together, work with the team, and thank you to all the participants as well.